Morning. My name is Jean Nagelkirk, and I'm the Special Assistant to the Provost at Grand Valley State University. On behalf of the Health Forum of Northern Michigan Partners, which includes Northwestern Michigan College, Blue Cross Blue Shield of Michigan, the Grand Traverse Regional Community Foundation, HealthSpark, Munson Healthcare, and Grand Valley State University, welcome to our panel discussion titled Healthy Aging in Northern Michigan. The purpose of our biannual Health Forum series is to offer a venue for discussion on topics pertinent to the well-being of individuals in Northern Michigan area. Through these forums, experts share information on thorny healthcare problems that we face daily. Grand Valley has been an integral part of Northern Michigan community for over 25 years, providing educational programming and services. We appreciate our strong partnership with Northwestern Michigan College and work collaboratively to build the healthcare talent pipeline for the Northern Michigan communities. As part of our commitment preparing the future healthcare workforce in our state, we value the contributions and collaborations we have with many of you who are in the healthcare and organizational industries. Grand Valley is especially pleased to co-host the Health Forum today as we offer several programs at our Traverse City Regional Center. Not only do we provide in-person instruction, we provide online and hybrid course delivery as well, giving individuals the opportunity for choice. These programs include undergraduate degrees in allied health sciences, health information management, integrative studies, nursing, and respiratory care. We also have graduate degrees in physician's assistant studies and educational leaderships at the master and the specialist levels. Today, our expert panelists will provide information on healthy aging, share statistics on population demographics, discuss models of care, services offered, and end-of-life care options. Before we begin our presentation, I would like to take time to thank Blue Cross Blue Shield of Michigan, our sole sponsor, and David Brown, who I think is on the Zoom. Thank you for providing the sponsorship. I'd also like to give special recognition to Shannon Owens, the director of Grand Valley's Traverse City Regional Outreach Center, and Shannon Dale, the director of communications and external relations in the Kirchhoff College of Nursing. Without those two, we would not have this event today. They have been organizing and coordinating things, so thank you so much. Now it is my privilege to introduce a colleague, Margarita Cotto, who is the Vice President for Lifelong and Professional Learning at Northwestern Michigan College. She will provide opening remarks. Marguerite?
Thank you, and good morning. It's a pleasure to join you, and Jean, let me thank you for that introduction. And to all of you, let me welcome you on behalf of Northwestern Michigan College to what has been a rich and timely set of presentations from area experts hosted and prompted by Grand Valley State University, one of the founding partners of the NMC University Center. 2 items of note. We are still living in the post-COVID transition. One of the most important things that it has given us is the ability to use this type of remote technology to extend the reach from just hosting face-to-face, which we hope to do again in the spring at our Haggerty Center campus, and extending to all of you who are professionals and interested citizen stewards of the great questions of healthcare and well-being that impact the citizens of our region. We're pleased to have the quality of programming that Grand Valley has shared for our region through the University Center. We look forward to future years of extended partnerships, enriched community engagement on the matters of healthcare that impact us all. Someone who knows a lot about that has been our longstanding moderator, Dave Mengebeer, who serves as the president and CEO of the Regional Community Foundation. He comes to us from a career. He arrived here at the helm of the foundation in 2018, and he served prior to that with Consumers Energy, leading work at many, many levels, looking at the impact of philanthropy and the impact of community engagement at both the legislative level, the philanthropic level, and certainly, as we see now through the work of the regional foundation, at the community and citizen level. Engagement looking at all citizen interests is of the utmost value, looking at the dashboard that has been developed by the Regional Foundation that takes a close look at the standards of health for the community at large. So again, thank you, Jean. Our appreciation to Grand Valley. Welcome to all of you. And let me hand it off to our moderator. Welcome, Dave.
Thank you, Jean, and thank you, Marguerite, and good morning to our audience, and welcome to the Health Forum of Northern Michigan and today's session on healthy aging, hosted by NMC and GVSU, and I'll add my thanks to our sponsor, Blue Cross Blue Shield. I saw a quote from Betty Friedman this morning pointing out that aging is not lost youth, but a new stage of opportunity and strength. Healthy aging is a particularly appropriate topic because the fastest growing demographic in our region are people over the age of 55. So what strategies should we as a community consider to help ensure a healthy aging population? Our panel of experts are here to answer that and other questions about aging this morning. Before we get into the presentations, just a few housekeeping matters. Each of our panelists will give a 10 to 12 minute presentation. Once the presentations are completed, we'll call the speakers back to our virtual stage for a joint Q&A. We're broadcasting through Zoom webinar this morning, and you'll find there's a Q&A tool when you hover your cursor at the bottom of your screen. We encourage you to go ahead and submit any questions you may have for our speakers during the presentation, so we'll be ready for that portion of the event. If you'd like a specific speaker to address your question, please indicate their name in the question itself. After the event, we will post slides for those speakers who have given us permission to do so. The website will be listed in the chat box for you. Closed captioning is available for this session by clicking on the box at the bottom of your Zoom screen. Our first presenter is Dr. Christine Nefsey. Dr. Nefsey serves as Chief Medical Officer for Munson Healthcare, providing strategic direction for clinical initiatives and strengthening clinical practices across the Munson system. I'll turn it over to you, Dr. Nefsey.
Thank you so much, Dave, and thank you everybody for having me. If we'll go ahead and pull up the slides. Thank you so much. So I wanted to start off about rethinking our traditional cultural thoughts about aging. So we'll go to the next slide. I think the first thing that we should acknowledge, the elephant in the room, that life has a 100% mortality rate. So, you know, all of us are going to get there. I think the question really is, how do we get there? You can see here, there's a lot of graphs that show different ways that people reach their end of life. And I think that that focus is probably part of our problem. So I'd like to reframe that. Next slide. First, as Dave mentioned, I do think it's important to acknowledge that in Northern Michigan, we do have an older population by percentages. We're in the top 10 of states that have the largest percentage of people over the age of 65, compared to someplace like Utah, where a solid third of their population is kids. We're just not in that same range. And so you can see that gray and yellow part of that graphic there is 45 to 65. Over half of our population really would be in what we would consider the older part. If you look there at our Northern Michigan map, you can see where we are projected to change or not change. And really, we're not projected to change very much. So we expect that that demographic will continue over the next few years. Next slide. So when we talk about changing our perspective on aging, it really, in large part, is from where you're sitting, right? If you're in that older population, you probably have a different way of thinking about it than if you're in that younger part. Next slide. So I want to talk really here about a paradigm shift. We hear a lot of negativity about aging, and it's very much, I think, a medical model that focuses on the pathogenics of aging. What if instead of saying this is a person who is a diabetic or in heart failure or is not mobile, we said more about what that person wanted or what was important to them. So what that is called a salutogenic model, and it really embraces what makes people healthy rather than what makes them sick. Another way to say that would be, it's not how old you are, it's how you are old. Next slide. So if we look at what does make people healthy, there have been a huge number of studies that show social connections are it. Over 148 studies with lots and lots of people show that people who have social connections live longer and they live healthier. Older adults who volunteer, as an example, are much less likely to have high blood pressure or cardiovascular disease or cognitive impairment. Other studies have shown that the clinical impact of social isolation is greater than that of obesity and many other traditional diagnoses. There are other studies called the Blue Zone Project that really looked at places that have long lives, so places like Okinawa or Sardinia. And what they have shown is that you can predict somebody living a longer, healthier life based on a few things. A plant-based diet is certainly helpful, continued low impact activity, having downtime and a sense of purpose. But one of the really important pieces of those Blue Zone projects showed us that people who live long, healthy lives always have social connectedness. Next slide. Not to get super sciencey on people, but basically what this shows is that there are certain inflammatory proteins called cytokines that impact the immune system. Another way that people have offered this is through the term toxic stress. But what this shows is that when those cytokines are there, they cause pain, they cause inflammation, and there are short-term and long-term impacts to that. And one of those is isolation, and isolation causes depression. I think everybody probably knows, if you look at some of the emotional and health effects that you see on the right side of the slide, that none of those things are going to be good for one's health. Next slide. In fact, this has been so well studied, and it is so important that the World Health Organization has created a framework called age-friendly communities, where they encourage people to look at community healthcare, transportation, housing, social participation, how our outdoor spaces and buildings impact access, respect, social inclusion, civic participation, employment, even communication and information. And if we adjust those and look at them in the framework of reaching out to our older population, that can have a long-term impact on people's health. Next slide. There was a great long-term study called the Frome Project that came from Somerset in the United Kingdom. And it was a 3-year study that showed when people were isolated for health reasons, and they were supported by what they called health connectors and community connectors, they were much less likely to be hospitalized acutely. So what that means, not necessarily that it was an emergency, but it wasn't a planned admission. There was a 17% reduction in the people that were prescribed community versus a 29% increase in the control group of similar people in the town that were not included in that project. And when they prescribed community, what they did was they did things like prescribed joining a choir or started lunch clubs or exercise groups, writing workshops. One of my favorites sounds very British, men's mend sheds, where community members got together and they fixed stuff for other people. But basically, older community members were linked together through the health and community connectors, and they were linked in something that they were passionate about or that they enjoyed. Next slide. So my question for us today is, what about us? You know, we're a foodie town. We have lots of cool stuff to do, beautiful places to be. I put a nod here to euchre because my husband and I started a euchre club when we moved here. That is actually a great source of socialization with our friends and a fun thing to do. And we certainly have the demographic. So what if Northern Michigan was a place where age wasn't viewed as a crisis or a silver tsunami, but rather an opportunity? What if we really looked at our older population and what they have to contribute to us rather than looking at them as a burden? How would we prescribe community? Next slide. So I will leave you with that question and then just the thought that health is a state of complete physical, mental, and social well-being. It is not merely the absence of disease. I think as we consider that statement and our opportunities, that is a good place to launch off today for a conversation of how we talk about aging in Northern Michigan. Dave, you're on mute.
Thank you, Dr. Nefsi. Our next co-presenters are Heidi Gastine, who is the Executive Director of the Area Agency on Aging of Northwest Michigan, where she served for the last 7 years, and Deborah Allen, who is the Chief Development and Community Engagement Officer for Grand Traverse Pavilions. Heidi and Deborah.
Good morning. May we have the slide deck, please? Thank you. Next slide. I love Dr. Nefsi's presentation this morning of how we reframe aging. And actually, as Deb and I were working on this presentation, I picked these graphics because the trees reminded me of how beautiful trees get as they get older and as we add the rings, and that there is a lot of beauty in aging, and we do need to have a community conversation of reframing what aging is. So with that today, we'd like to talk a little bit. Deb and I are going to tag team. We're used to doing a roadshow together, so we're going to play off of each other. What do we mean by successful aging? But then we're also going to get into types of care continuums. We've got some questions, provocative questions, that if you are an older adult or caregiver, or if you are in the healthcare profession, how to key up helping people to prepare for successful aging, and then wrapping it up. Next slide, please. So the Area Agency on Aging of Northwest Michigan serves 10 counties from Manistee, Rexford, and Missaukee all the way up to the Bridge. We have many different roles, from being a regional planning entity for aging needs to providing unbiased information and resources, to offering various programs. And if Deb could give a little bit of overview of the Grand Traverse Pavilions, please.
Good morning, everyone. And I so appreciate the opportunity to share this information with you this morning. I have the honor of representing Grand Traverse Pavilions, which is a municipal organization. We are a continuum of care. You'll hear more about what that means. But basically, for the Grand Traverse Pavilions, what that means is we provide care from independent living, assisted living, to skilled nursing care, which you'll hear a little bit more about that, as well as the traditional nursing home care. And we have ancillary services such as our rehabilitation services and our ELM unit, which is a memory care unit. So again, thank you so much for the opportunity to speak with you today, and I'll turn it back to Heidi.
Thank you. May we have the next slide, please? So as Dr. Nefsi pointed out so eloquently, we are poised to have a conversation about what does aging mean in our communities and the importance of age-friendly communities. At least, depending on how you're defining the region, 1 in 3 people are over the age of 60. And that has a lot of implications. First, the baby boomers are the largest cohort up here. And that means that in 2021, right now, the oldest of the baby boomers are starting to turn age 20 at 75. In addition to that, we know that the 80 plus demographic is the fastest growing demographic up here, as well as in the state of Michigan. And so that has a lot of implications when we think about our community designs. If we think about some of our communities, not so much Grand Traverse County, but some of the outlying communities, we actually have death rates that are exceeding the birth rates. So we have communities comprised of older adults, but we haven't necessarily planned for what that means with our socialization, with our trails, with our community infrastructure. The other thing is that 75 seems to be, at least with our internal data, the magic age of where there's an uptick in a need for supports and services. And this comes back to that idea of social isolation and community and how we care for those individuals so that they aren't alone and they are able to age in place if that is their desire, or age in the environment that they desire to. And they've got quality of life as they define it. Next slide, please.
Oh, Heidi, if we could for just a second,
Yes.
I'll just
Sorry,
add on.
Deb.
That's all right. I'll just add on a few things. We don't need to change the slide back, but just some things to pause for a moment and think about in regards to the societal and cultural ramifications of the demographic shift, as Heidi alluded to, that what will families or extended families look like? Who will be taking care of mom and dad or Auntie Deb? The sandwich generation that we've heard about before may become the club sandwich generation. And what I mean by that is not only do you have individuals taking care of their children and their parents, but you may see them also taking care of grandchildren and potentially even an extended elder population. So that combined with what will be the impact on housing, as baby boomers account for 33% of households right now, what seniors or will seniors who have the majority vote support school millages as a need for services for seniors outweigh the need for children. As Heidi mentioned, there are currently more people aging out or dying than there are being born in our society right now. And seniors are driving the US economic engine, with almost 53% of US household net worth in the United States being held by those individuals that are 60 plus. And our region has one of the highest percentages of baby boomers in the nation.
Now you can see why Deb and I do a tag team show. Thank you. So just for giggles, I Googled what are the steps for healthy aging? And as Dr. Nefsi pointed out, the typical list came back. So staying active, make sure you're eating well, staying socially active, make sure you go to the doctor, get your screenings and your checkups, take your medications as directed, limit your alcohol and don't smoke, get enough sleep and manage stress. And Dr. Nefsi's slides pointed out the implications of chronic stress and not having enough sleep. This applies to any age. But I think that if we think about aging in our communities, next slide, please. One of the bigger, more fundamental questions is who will take care of me when I'm old? And this gets to that social connection, as well as to what is our family infrastructure, as Deb just mentioned. So who is taking care of Auntie Deb, who's going to help me as I'm in the club generation here? It gets very complicated. And with that, I'd like to turn this slide over to Deb.
Well, when we saw this book cover, first of all, I put my order in right away because I'm quickly I'm part of that baby boomer generation. But it's interesting that they say everything you need to know to plan for your own safe, financially secure, healthy, and happy old age is in this book. And we've already said it, successful aging is a choice. Even choosing to do nothing is, after all, a choice, perhaps not a good one, but there are certainly things beyond our control. But if you are approaching or caring for individuals that are approaching over the age of 60, I sincerely hope that you've given thoughtful consideration already to what you have or can do to prepare for a positive aging experience. Next slide, please.
So as Dr. Nefsi started out her presentation, we often in the medical community think about healthcare as a medical or aging as a medical condition. And so we wanted to start out with just kind of defining the continuum of care from a healthcare perspective, and then move into more of the long-term care continuum. So if we think about all of these different types of resources and specialists are involved in the care of an older adult. So on the acute care side, you have the primary care physician and the specialist physician. That could be the cardiologist, the endocrinologist. And then when we've got episodic things acting up, at the urgent care in an emergency room in the hospital. So that's at any age. When things become a little bit more complicated, skilled care is also an opportunity. So you can have individuals coming into your home. This is often Medicare paid for, particularly after a hospital discharge or recovering from an acute illness. You can also be discharged to a skilled nursing facility for rehabilitative services or into palliative and hospice care. So these are all paid for under Medicare. And I want to stress that, as Deb alluded to on the previous slide, the financial planning is one of the most important things that you can do to prepare for successful aging. So it's not only our mindsets and our attitudes and our social connections, but figuring out how are we going to pay for what we need. So I'm calling out that Medicare really only pays for those first two blue boxes in this screen. If you need something beyond that, then you're entering into other payment systems. So when you need long-term care on the continuum, so let's say that you went into the hospital, you had a stroke, you did some rehabilitative services within a skilled nursing facility. Now you're starting to move into or it's a spend down, or it's Medicaid. And so that's going to give you the longer term care. Think about it.
So a couple key concepts about continuum of care. So in healthcare, as Heidi mentioned, the continuum of care is now being used to describe how healthcare providers follow a patient or a person from preventative care through medical incidents, rehabilitation, and maintenance. In simple terms, where a person is on this continuum is based on how much help they need, not just to survive, but to thrive. And these days, the larger part of the conversation will be how will you pay for your care? I do want to take just a quick minute and talk real quickly. We've heard about all these acronyms, CMS and DHHS and those types of things. And so just for clarification, CMS refers to the Centers for Medicare and Medicaid Services. They are managed federally within the U.S. Department of Health and Human Services. We've heard that term a lot, that works with state government to administer the Medicaid patient. Just real quickly on Medicare, Medicaid, and I am not an expert, so I defer to Heidi on this, but just to kind of ways that I remember these things, is that Medicare is a federal program for aging. I always remember the care, the A in care relates to aging, age 65 plus. Medicaid is a state program that has an I in it, and because it's income-based. So that deals with things like home health care, prescription drugs, case management, physical therapy, occupational therapy, et cetera. So when we talk about this alphabet soup, sometimes it's a little confusing, but what it really comes down to is ways to break down the different segments of care, and also talk about what Heidi's going to talk about as activities of daily living and how we measure that in our society and how we bill for those things. So Heidi.
Next slide, please. So when we start to think about the long-term care continuum, it's really about how are we taking care of ourselves every day. And so activities of daily living refer to bathing and dressing and grooming and eating and cleaning up around after yourself, the things that we do and take for granted, most of us, most days. When we get into instrumental activities of daily living, these are shopping and transportation, preparing meals, housekeeping, managing finances, and taking medications. And when you start to struggle with these activities, it's a signal that it's a time to start looking at who's taking care of you, that long-term care system. Deb beat me to the alphabet soup. I'm really glad she did that. If we could have the next slide, please. This is a really busy slide. And I kind of want to start from left to right. So as Deb said, in the long-term care continuum, it's about making sure that people have not only what they need to survive, but to really thrive. And it's a very person-centered approach. So there's, as you can see on the screen, there's a bazillion options that can all be put together depending on your financial situation. And everybody's needs are unique for what they want for their quality of life. And answering that is a really important question. So if I start from left to right, actually, I'm going to start at the payment sources. So that first asterisk, private pay or cost share, we hear about saving for retirement. And this is one of the major reasons to save for retirement. We do not have a funding system that will cover everything in your long-term care needs. So many things are either private pay or you're paying a portion of the cost of it. As Deb said, Medicaid is a state-funded system. There are programs where Medicaid and Medicare are combined together, such as the PACE program. Medicare is a federal program, typically covers your healthcare, so your doctor's visits, your hospitalizations. But everything becomes situation dependent. And if you have a long-term care insurance policy, you've got even more options. So if I go back to the boxes, Deb and I are going to, in the next few slides, tag team our way across the different options in the long-term care continuum. Next slide, please. So if we think about the home and community-based options, and that's about really 95% of the 60+ population, there are many, many ways to put your care together. And so we talked in the beginning about the importance of the Euchre Club and our social groups and our families and friends and having children and family members around us. So who's caring for Auntie Deb? How is Heidi caring for mom and dad as well as caring for children? How are my parents helping with my children? All of that. And actually with the pandemic, we've seen it become even more dramatic as families have come together, as economic situations have changed, as there's more grandparents taking care of grandchildren, and that reversal of roles when you have someone who is perhaps failing in their health, but they're also trying to take care of a 2-year-old. All of this is up in the air in the last 2 years with the pandemic. If we move into the more formal, this is where we have most of our counties, actually all 10 of our counties up here, 11, 12, have senior millages. And so these senior millages often help to fund things like senior centers, Meals on Wheels, and commissions and councils on aging. And depending on what kind of community you live in, you may have any kind of combination of these services, but the general is senior centers are going to offer activities and often congregate meals where seniors can get together and have meals together. Meals on Wheels will bring meals to the home, particularly for those who cannot get out due to health and frailty. Those rules have been relaxed with the pandemic. There's the qualifications to get Meals on Wheels are much more loose right now. And then commissions or councils on aging often offer services that can come into the home. And these are often millage based. There's different criteria depending on the county, but they can help with the personal care, those ADLs and those IADLs that we talked about a few slides ago. As we move further in, oops, sorry, can you go back real quick? Thank you. Senior housing and adult daycare. So there are places to go and get assistance during the day, to have housing centers that will help with some of the needs. Private duty is always an option if you can pay for it yourself, and that's having an agency come in to help with your ADLs. There's programs through the Area Agency on Aging and that we have for care managing to help organize and identify when a person has needs, and that's often offered through the commissions and councils on aging as well. The My Choice Waiver Program and the PACE program will both offer nursing home level care in your home. These two programs have very different structures. The PACE program includes your Medicare and your Medicaid services, so you can get your health care and your long-term care all in one stop. The My Choice Waiver Program is going to put nursing home level, the assistance with the ADLs and the IADLs into your home. And then palliative care and hospice will be covered in a future presentation. Next slide, please. Deb.
No, I think really what Heidi's basically saying is we all want to live ideally, in our own home for as long as we can. And so, many people need to start having those conversations with family, finding out what resources are available. And just in terms of a key concept, we talk about home health care. So just kind of healthcare, home health care is healthcare or supportive care provided by a professional caregiver in the individual's home where the patient or client is living, as opposed to care provided in a group accommodation, such as clinics or communal living facilities, nursing homes. And home care is also known as domiciliary, there we go, care, social care, or in-home care. And so we encourage you to take a look and think about those things. Do you want to live in a communal setting? Do you want to live in your own home? And then how do you make the decisions and the planning for those things moving forward? So we moved on to the next slide. And so breaking it down, did I miss one?
Nope, you're good.
Okay, so no, I think we may have also, I had a couple notes in terms of independent living. We talked about that, and I think, okay, so I'm good, I'm sorry. So let's move on then to the questions, important questions to ask. Heidi, you want to take the lead on that? And then we'll...
Sure. So thinking about what are the quality of life you want to have, and these are questions to ask yourself, to ask individuals you might be caring for, or in our professional roles, to prompt individuals to think about these questions. So what do you want your life to look like? Do you want to be living at home? What kind of socialization do you want? Are the trails important to you? Is a Meals on Wheels important to you? How do you want your family to get together? If you don't have family up here, what do you want to do? How do you want your life to look like? What kind of environment do you want to live in? Do you want to live in your home? Do you want to live in a communal setting where you've already got a built-in social network? There's all kinds of those options. Who do you want to take care of you when you need that assistance? It's really that fundamental question. What can you afford? Do you understand that the Medicare and Medicaid and other funding sources, what they will or will not pay for? And by the way, I want to put a plug in that everyone over the age of 65, which is the age to qualify for Medicare, should have their Medicare plan reviewed each year. The benefits change. There's straight Medicare, there's Medicare Advantage plans, there's drug plans, and it's just a really good thing to have that reviewed by someone every year. Who do you want to make financial decisions for you? Who do you want to make care decisions for you when you can't make them? What kind of care do you want to have? And I'm sure that when we get into the palliative care and hospice conversation, this will be covered in more depth. But do you want progressive or life-saving care? Do you want palliative and comfort care? Who do you need to have these conversations with to make sure that those around you know what you want? These are all important questions that help to getting to defining what you would like your life to look like. That being intentional about how to age. Deb?
I think there were a few key concepts that maybe on the previous slide, which is why I stuttered a little bit, just kind of want to allude to. So when we talk about this care continuum in the nursing care facility, we talk about things like skilled nursing facility. What does that mean as opposed to maybe the assisted living that Heidi had referred to in the residential setting? So just for clarification, when we talk about skilled nursing facilities versus nursing homes, skilled nursing care is typically provided for rehabilitation patients that don't require long-term care services, but nursing home care provides permanent custodial care, where a skilled nursing facility is often more temporary to solve a specific medical need or allow for recovery outside of a hospital. So these are just some key terms to be aware of, which are sometimes referred to as SNPs, because that's the acronym, that vegetable soup we talked about, includes senior care meal preparation, and also specialized staff such as speech language pathologists, which obviously I might need this morning, rehabilitation specialists, audiologists, among others. These medical professionals are not typically staffed in a nursing home. So skilled nursing care is typically provided for rehabilitation patients that don't require long-term care services. So again, just helping you to understand the continuum of care and some of these key phrases and key terms as you're considering where you are, or where the people that you may be helping to assist determine what needs they have. These are all acronyms or terms within the industry to be familiar with. Thank you.
Next slide, please. Deb, did you want to take this one?
Sure. So some caveats about long-term care. What we hope that each of you will take away from this segment of our discussion and the entire program today is successful aging is ideally a choice. The concept of aging care continuum is an extremely complex system, one that is ever changing as insurances, federal support for Medicare, Medicaid funding is currently being debated, all while the demands for services increase as the unprecedented number of baby boomers age and their healthcare needs intensify. So there's a new reality on the horizon as we consider the impact of national healthcare worker shortage. The sustainability of the care model for aging adults is simply an unknown. So it's all the more important that you plan now, you make these decisions, you think about what type of care individuals need or want going forward. So we beseech you or beg you to plan now with you and your family. And we know that you will be glad that you had these difficult conversations now.
Next slide, please.
And the next slide is about many avenues for assistance. So you've heard from Heidi, and the Area Agency on Aging offers just a plethora of resources. And another resource that we wanted to point out to you, if you're someone that is not maybe as tech savvy on the computer, there are other resources such as, I don't know if that's going to work, I'm sorry, with my screen, but the Primetime Senior Directory is a resource guide that lists all of the local service providers at different levels of the care continuum. And those books are actually available at the Area Agency on Aging, as well as many other senior centers throughout our region. So if you're interested, perhaps that would be a place to start, to have a one-stop guide that has a lot of these materials in them for your use. Heidi, anything to add on that?
You did a great job. So if there's further questions that we can ask after or answer after the presentation, here's our email contact information for both Deb and myself, and we look forward to being a support to you. Thank you.
Thank you, everyone. Dave, back to you.
Thanks, Heidi. Thanks, Deb. Our final presenter this morning is Dr. Roman Barraza. Dr. Barraza is the medical director of Munson's Palliative Medicine and the medical director of Munson's Hospice Care Program. Dr. Barraza.
Thank you very much for the introduction. I'm just trying to get my slides up to share and demonstrate. So today I'm going to be touching on three general topics I was asked to present on today. One is on the general concept of advanced care planning considerations. I was also asked to speak about palliative care and hospice care. I'm going to divide that up into end-of-life considerations. Well, I'll focus on describing hospice care, what it is not, and a brief overview of the hospice benefit. And then I'm going to close off with a description of what palliative medicine is. There is a distinction, and I think a lot of people in general confuse or conflate palliative medicine with hospice care or end-of-life care. So one of the things that I certainly want to make mention of is with regards to advanced care planning, one of the central aspects to advanced care planning is completing an advanced medical directive. I'm going to show just a couple examples of an advanced medical directive. One popular one nationwide is a form called the 5 Wishes document. This is an advanced medical directive. And what an advanced medical directive essentially is a document where an individual can document who they would want as their primary or even alternative individuals or people in their lives to make medical decisions if they couldn't make their own medical decisions. What kind of medical treatments they may or may not want, which is a reflection of their personal preferences and values with regards to medical treatment. If they are approaching a very critical ill phase of their life or even an end of life situation, what their priorities are. Are their priorities more on life prolongation, even at the cost of some degree of suffering? Or are their priorities more on comfort and quality of life, even at the potential cost of some less time? How they want their medical providers, doctors, and nurses to care for them and treat them. And then they can also document other personal preferences with regards to their care in general. An advanced medical directive, I oftentimes inform my patients, there's a lot of information that can be documented in an advanced medical directive. I make the case that the most important part of an advanced medical directive is delineating and documenting who you would choose as your primary decision maker. And this goes by a number of terms. Sometimes people will label this individual the patient advocate or the DPOA, durable power of attorney. And this is specific to medical power of attorney, basically who makes medical decisions for yourself. And what I want to clarify is that this is not the same individual or the same thing as, quote, an emergency contact, a very different thing than an advanced or a medical advocate, if you will. So the question to ask oneself is, if you were to become so sick that you could not speak for yourself or make your own decisions for yourself, who would you want and trust most to make medical decisions for you on your behalf? The answer
Dr. Barraza, I apologize for interrupting, but we're not seeing your slides advance.
Okay. Let me reboot this then. Are you able to view my slides now?
Yes.
Throughout this talk, were my slides not showing at all?
That's correct.
Okay. So just very briefly, just for visual, these are just some examples. This is the 5 Wishes document that I had made mention of previously. This is an example of an advanced medical directive that is commonly distributed throughout Northern Michigan. This is provided to within our Munson healthcare facilities and clinics. And this is the portion of that document that I oftentimes advocate or emphasize to my patients is one of the most important parts. Who would speak for you on your behalf if you were to become so sick that you could not make your own decisions or speak for yourself? And that's an important individual to identify so that if you were to become so sick and you were in the hospital and doctors were wanting to know what you would or would not want, that we're going to that appropriate individual. And when my patients complete an advanced medical directive, and I've finished telling them that the most important part of this advanced medical directive was to identify and document who they would want to make decisions for themselves, I then oftentimes tell them, once they've completed and signed the advanced medical directive, I sort of lied to you. That's not the most important part. The most important part of the advanced medical directive and advanced care planning is to have ongoing and evolving conversations with that durable power of attorney or patient advocate, that person that you would trust most, about what you would most want or not want in your care, what your values and preferences for your life, for your quality of life, and for your preferences in care are, so that way that individual is best prepared to be able to speak for you on your behalf. What I oftentimes tell patients is what we don't want for your advocate is for them to feel the burden of making a difficult decision for you. Instead, if you have those conversations with your advocate, should they have to speak for you, should only feel the duty of honoring your voice. This is an example of an advanced care planning workbook, and I oftentimes encourage my patients to complete an advanced care planning workbook that will help inform and guide what that advanced medical directive looks like, and hopefully inform and guide conversations that they have, not just with their patient advocates or their medical power of attorney, but also with their doctors involved in their care. So this is an example of a portion of that workbook. It's a meaningful living worksheet. And oftentimes this can best inform how we should care for a patient if they were able to answer these kinds of questions ahead of time. So for example, this worksheet prompts the patient to consider a number of different situations or circumstances or physical or cognitive limitations that they might have, and whether or not that aligns with a meaningful and acceptable quality of life that's worth living and pursuing life-prolonging medications and treatments for, or whether they would want, alternatively, a comfort-focused plan of care that would allow them to live a natural life and also experience a natural and ideally peaceful death if they became this ill or debilitated. So for example, if I could not think clearly and I'm confused most of the time, would you want your life prolonged intentionally by doctors and nurses involved in your care if you were that ill in a permanent manner? Or if you, going down the list, could not feed yourself and you needed to have others to feed you most of the time, would that be a quality of life that would be acceptable to continue prolonging or not? And so when a patient completes this worksheet, for example, I and their other physicians involved in their care can best guide them about how and what medical decisions would be most appropriate and consistent with their values and wishes. I'll offer a few plugs to some resources in our Northern Michigan community that can help with these things. One is our routine and regularly occurring advanced care planning workshops. Since the COVID pandemic, these have been offered through a Zoom platform, and this is led by our advanced care planning director, Stephanie Van Slyke, here at Munson Medical Center for the entire Munson healthcare team. And these workshops can help any patient, regardless of their health status or degree of illness that they may be living with, complete an advanced care planning workbook, understand the importance of having those conversations with their loved ones and advocates, and go through what an advanced medical directive is and how to complete it. And I'll also offer a plug from one of my colleagues out at Harvard, Dr. Angelo Volandes, who wrote a book titled The Conversation. This is a very easy to read for any individual and intended toward a layperson about how to think about aging, living with chronic illness, and planning for end of life for whenever that time may come. So with regards to end of life considerations, I want to talk about hospice care. I know that this forum is on healthy aging, and some people might initially question, if we're talking about healthy aging, why are we talking about dying? And I would argue that dying is very much a natural and normal part of life. And that when we talk about living healthy, it's really talking about living well and living with a general sense of well-being. And there are better and worse ways to spend one's end of life, whether we're talking about someone's final days, weeks, or even several or many months of life, and how they spend that time of those chapters or that chapter of their life. And I want to make a specific mention about hospice care, because hospice care is a very valuable resource available to anybody who's knowingly approaching their final days, weeks, or months of life, and could benefit from the valuable resources from hospice care. So as time begins to run short, if you know that you have an illness that is not curable and is life-limiting, some important considerations for everybody to consider are, where do you most want to spend your precious limited time? How do you most want to spend your precious limited energy? Because as we approach our end of lives, oftentimes our energy is limited. So those are two very important considerations. How do you most want to spend your limited time? How do you most want to spend your limited energy? The answers to those questions can oftentimes guide and inform the best way to pursue your general life, your health, and your healthcare choices. As time begins to run short, what becomes most important to you? What is it that you most want your family and your loved ones to know about you, thinking about a legacy? And what do you want your doctors to know about your personal values, wishes, preferences for care? So that way we can be best informed to best guide your care that's consistent with your wishes and preferences. For those who are wondering, what is hospice care? A brief definition or description is that hospice care is specialized type of care, and I will use the word dichotomy. Hospice care is a dichotomy of care where patients who are in their final stage or stages of life and have made certain choices can receive this hospice care benefit. This is care that's reserved for patients who are in the terminal or final stages of their life, living with a terminal illness, arbitrarily defined as their final 6 months of life, where patients choose to forego life-prolonging or aggressive, maybe curative intent or life-prolonging intent treatments because they oftentimes are causing more suffering or more distress or coming with more side effects that are impacting their quality of life. The patient's goals include optimizing quality of life and foregoing further hospitalization and studies and tests and procedures which are not expected to improve their comfort. Quality of life is optimized by addressing all aspects of care, including their physical needs, psychological needs and symptoms, emotional and spiritual aspects of themselves. So hospice care provides that emotional, physical, and spiritual support by a multidisciplinary team that includes a team of doctors, nurses, medical social workers, chaplains, spiritual care advisors, and therapists to help meet a patient's needs during this stage of life. These providers will make routine visits to your home or wherever you may call home, whether that be a skilled or a long-term care facility or a hospice house residence, for example, to make sure that their comfort and quality of life needs are met. And again, hospice care focuses on comfort, provides medicines, medical equipment, supplies, and even some assistance at work from those hospice nurses' aides to help with things like bathing and whatnot. It also provides support to the family, and that also comes in the form of bereavement support to the family after a patient passes. The significant benefits or highlights of the benefits of hospice care include, and what I want people to know is that this is a Medicare benefit and typically a benefit of most private insurances. I mentioned earlier that is a dichotomy of care. So when patients choose to activate their hospice benefit, they are also choosing to forego or deactivate, if you will, the coverage and provision of certain treatments that are not aligned with the hospice care philosophy that I described earlier, such as ICU care or PET scans or pursuing more chemotherapy, for example. So the hospice benefits include the 100% coverage of medications required and needed to manage symptoms related to their terminal illness, 100% coverage of medical equipment like a hospital bed, supplemental oxygen in the home, any medical supplies for wounds or wound care, for example, 24/7 availability through the telephone of that hospice nurse. So 24/7, whether it's 2 o'clock in the middle of the day or 2 o'clock in the middle of the night, if there's some issue that the patient or caregiver has who's enrolled in hospice care, they can reach out to their hospice on-call nurse, and a triage nurse is available 24/7 to address any very simple or basic questions or respond to some symptom crisis or emergency or urgent situation where they can start guiding the caregiver what to do by phone and also subsequently say, and I'm on my way, I'm going to the home now to help manage the situation. It provides the social worker and counseling for patients and families, spiritual care support, home health aides and trained volunteers, and bereavement support for at least a year after the patient deceases. I want to make mention, and this was touched on previously in the previous presentation by Heidi and Deborah, services that are not provided by hospice care is that the hospice care benefit does not provide a caregiver in the home 24/7. That basic routine assistance with caregiving is provided to the patient by the family, friends and loved ones, or maybe hired caregivers, privately hired caregivers. The hospice benefit does not provide room and board cost coverage if a patient is living at an assisted living facility, a nursing home, or a hospice house residence. The daily costs of living in any of those facilities is an out-of-pocket cost to the patient. So who is hospice care appropriate for? It's appropriate for patients who have a life-limiting illness or terminal illness and whose goals of care include an exclusive focus on comfort and quality of life, and a preference to no longer pursue aggressive, oftentimes no longer beneficial treatments such as chemotherapies or advanced treatments in the ICU, for example, or more testings like X-rays and blood tests, for example. Oftentimes, as I mentioned earlier, palliative medicine or palliative care is oftentimes conflated or confused with hospice care. And that's why I left it as the last topic, to address. Palliative medicine, I mentioned earlier that hospice care is a dichotomy of care. Palliative care or palliative medicine is not. Palliative medicine is a medical subspecialty, the way cardiology or oncology or nephrology are medical subspecialties. Palliative care as a medical subspecialty focuses on providing expert medical care for patients who are living with a long-term, life-threatening or life-limiting serious illness. Palliative care is focused on providing symptom relief that come along with their serious illness, whether that be cancer-related pain or shortness of breath related to their emphysema, for example, and the other stresses that come along with a serious illness, like the situational depression and anxiety that oftentimes come along with a new diagnosis of a serious life-threatening illness. The goal of what palliative care teams do and provide is to improve quality of life for the patient and their caregivers while the patient is receiving ongoing treatment for their life-threatening or life-limiting illness. It's provided by a multidisciplinary team of specially trained doctors, nurses, and other specialists like psychotherapists, medical social workers, and navigators who work together with the patient's other doctors and specialists, their oncologists, their cardiologists, their primary care providers, to provide an extra layer of support and to help guide advanced care planning. Palliative care, as I mentioned, is not exclusive to end of life. It's appropriate and can be initiated at any age, at any stage in a serious illness, and it can be provided along with curative intent treatment. So palliative care, as I mentioned, the medical professionals who are experts in palliative care provide meticulous management of pain and other symptoms related to their illness. Psychotherapists, social workers, and the clinicians work with the patients and their caregivers to help relieve anxiety, worry, and depression that come along with a new diagnosis and living with a serious illness. And we take time for clear communication about what matters most. That communication oftentimes comes in the form of questions and discussions, such as, what do you understand and know about your diagnosis from what doctors have told you? Oftentimes, patients, when they see us, don't actually have a clear and accurate understanding about what their diagnosis is that they have, whether it's cancer or advanced heart disease or lung disease, for example. What do you know and understand about your prognosis? What are your goals? What are your fears? What are your hopes and worries? What would you like to do as time potentially runs short? And what are the trade-offs that you're willing to make? How much suffering or discomfort or burden are you willing to go through for the sake of the possibility of added time from some of the aggressive treatments that are oftentimes proposed for patients living with a serious illness? I been using this term serious illness. This is a short list of the kinds of diseases or diagnoses we're talking about where palliative medicine teams are appropriate. Advanced heart disease, lung disease, liver or kidney disease, cancer, neurodegenerative diseases like Alzheimer's disease and dementias, ALS, Parkinson's, etc. We're not talking about chronic pain from a work-related injury or someone with diabetes or hypertension. we're really looking at serious life-threatening or life-limiting diagnoses. And the palliative care team can be a part of that patient's care, even from the time of diagnosis. I want to emphasize what palliative medicine is not. It's not only end-of-life care. It's not an attempt to contain medical costs or ration care or try to persuade a patient toward or away from a specific treatment plan. Palliative medicine does not hasten death. In fact, I'll show you some information that suggests otherwise. And palliative care is not, quote, pre-hospice care. Oftentimes, a number of medical professionals and even people in the community oftentimes have this inappropriate and incorrect impression that palliative care is somehow pre-hospice care. To that point, I want to share with you a
We're having some
landmark study, and there are many
connectivity
colleagues
issues,
out at
Dr.
Harvard,
Barraza.
palliative static lung cancer. Can you hear me right now, or is it an audio or visual issue?
It's audio.
Okay.
You're freezing up a little bit on the video.
I'm wondering if I can get some technical support to try and figure out what the issue or limitation is.
We can hear you now. You can continue.
You're fine now, Dr. Barraza.
Okay. So in that study, they looked at over 150 patients and they randomized them into two groups. These are all patients newly diagnosed with lung cancer. And what they did is in one group, they provided your typical state-of-the-art standard medical care for a cancer patient at a cancer center where they saw a radiation oncologist, a medical oncologist, and all the other specialists that come along with a cancer center, the social worker, financial navigator, dietitians, et cetera. However, in the other group, they provided them with exactly the same thing, except they also referred them to an expert palliative care team to be a part of their care from the time of diagnosis. And to summarize, what they found is by every metric measured, they found that the patients who received an early palliative care referral throughout the continuum of their care with their treatment for lung cancer experienced better quality of life in terms of better symptom management. They also found that they had lower rates and severity of depression. And one of the reasons that this study garnered so much attention, they found that the patients who received early palliative care referral lived longer, on average 2 to 3 months longer than the patients that received routine state-of-the-art cancer care for their metastatic lung disease. Earlier, I made mention that palliative care is not pre-hospice care. This is an incorrect perception or model. A more appropriate model is to understand that palliative care, like any other medical subspecialty, is appropriate from the time of diagnosis of a life-limiting or life-threatening illness. And what you'll notice on this graphic is that in the newer model, in the lower portion, palliative care can be integrated from the time of diagnosis. As a patient's illness or disease progresses, palliative care may take on a greater role in helping manage symptoms or have greater discussions about advanced care planning. Oftentimes, these patients enroll in hospice care earlier, so they receive the benefits of hospice care for longer. And as I mentioned earlier and marked by that study, oftentimes patients live longer as a consequence of receiving early palliative care. So as a summary, palliative care is appropriate. It's a medical subspecialty that's appropriate at any age, at any stage of a serious illness. Palliative care helps patients to live as well as they can, for as long as they can. And we work with patients and their caregivers to assist with complex and difficult medical decision-making and advanced care planning. For those wondering, how do I get palliative care and find whether or not palliative medicine specialty groups exist in my region, this is an excellent website to go to, where you can go in and look in your own geography, type in your own zip code to figure out what palliative medicine clinics and resources are available in your community. And I thank you all for your attention and time today.
Thank you, Dr. Barraza. We're going to now turn to our Q&A portion of the forum. So I invite all of our presenters to turn their cameras back on and join our virtual stage. And just a reminder to our audience, if you have a question, you're welcome to submit it either in the Q&A or the chat box at the base of your screens. So the first question that we have is for Dr. Nefsi. Great presentation on a paradigm shift for healthy aging. How does Munson currently, quote, prescribe community, close quote?
It's a great question, and I think why I put it up there as a paradigm shift. I think we probably see pockets of it. And I think, you know, when we saw Heidi and Deb's presentation, there was that box on home and community, and the informal box was really tiny and the formal box was really high. And so I think what we need to do as a community is move that informal box into the formal box and work together so that it's not just Munson, but it's all of our fabulous resources that we have around here to start shifting that paradigm so that we make those connections for people. And we're not just as clinicians looking at the clinical piece of it, but we're looking much more broadly to the community piece so that we can then start to prescribe community and then have that answered on the other side, supporting people in what that looks like. So I'm not sure if I answered the question, but you know, we, like I said, I think we do it in pockets, but certainly not formally and certainly not on a grand community-based level.
Thank you. I think I'll direct this question to Heidi and Deb. Is the healthy aging solution merely a conversation to have among each other and with our clients, or a greater community design change?
It's a greater community design change, and actually Michigan has been designated as a healthy aging state or aging friendly state. So there's many initiatives going on across the communities. There are several, as Dr. Nefsi said, pockets of our communities already working to become aging friendly communities. It is a design challenge, it is a conversation, and it takes all of us to think about what do we want our communities to look like going forward. Deb?
Excellent summary. And I think the only other thing that I would say is that, you know, these are unprecedented times. We've heard that phrase so many times, but we are absolutely in the midst of a healthcare challenge, a healthcare crisis, it's been called, in terms of our healthcare workers. So the systems that have been in place for many years may change, may need to be altered to address some of the challenges in the healthcare worker shortage right now. So I would encourage people to stay informed, to have these conversations and ongoing conversations with professionals, with your medical professionals, with organizations such as the Area Agency on Aging. And this is an effort that's going to be ongoing and evolving and driven by this demographic shift over the next couple of years.
I would put an additional plug into not just the healthcare and the Area Agency on Aging, but how do we take this conversation to our philanthropy friends and our chambers and make it a true community effort.
The next question I'm going to direct towards Dr. Barraza. Are the advanced care planning workshops available to anyone or only to patients within the Munson healthcare system?
Good question, and they are certainly available to anybody in the community. If you do a general search online, whether you use the Google search engine, if you just type in Munson Advanced Care Planning, you will be taken to the Advanced Care Planning webpage available to the public to see, and you can read about advanced care planning and also get information about the workshops and the schedule of those workshops and even the materials that are provided along with that.
Thank you. So I'm going to ask first Heidi and Deb to respond to this question relating to the built environment. What are some ways that we can ensure age-friendly built environment in Northern Michigan? For example, significant evidence exists indicating the built environment correlates to increased physical activity among seniors. Downtown city sidewalks, for example, are often covered in ice during the long winter months, limiting seniors' access to downtown amenities.
Deb, you want to go first, or would you like me to?
Sure. So I think this ties into what we were previously just discussing, that as we talk about healthy communities, healthy aging communities, these are all elements that are part of the discussion. You know, a lot of these things used to be covered through discussions with the ADA, the American Disabilities Association. And, you know, these conversations need to continue to happen again, wasn't that long ago that here in Grand Traverse region, we were very proud of the fact that we were one of the top 25 places to retire. And now we have seen people coming in groves, and now we've become this, aging community, and there are a lot of infrastructure related challenges that are associated with that. So these are conversations that need to happen again with our elected officials, with our planners, community planners, to start thinking about how do we best arrange our community to be able to be beneficial for all, not just aging adults, because a lot of those same issues, maybe slower crosswalks, so that people can get across the street easier, benefit not just our aging adults, but also mothers with small children. So I think these are conversations that just need to be had, and thoughtful discussion on how we can benefit everyone in our community.
That was very well said. Thank you, Deb.
This question, I'm going to start with Dr. Nefsi, and maybe Dr. Barraza would like to chime in. Does Munson have an overarching strategy to address our region's aging population?
That's a great question. I think certainly we are very aware of that demographic and what that means for us as a healthcare institution. So I would say, we have addressed it in a couple of ways. One would be your typical preventive measures, so emphasizing things like diet and exercise, screening exams, those kinds of things. Additionally, we have really taken some steps about access, so hiring more primary care physicians and providing more access through a virtual platform for those people who may not be able to readily come to clinics and those kinds of things. And then the other one is Dr. Barraza and his program, and investing in the awesome work that he and his partners do to address some of the very specific issues around aging. So that doesn't mean we have work to do. To point out from the earlier question, I think that paradigm shift and coordinating better with our community through our community health programs and specific to community health programs for aging is certainly something that we have lots of opportunity with. But I will pass on to Dr. Barraza to speak more formally about his programs and the investments we've made in the community that way.
Sure. I'll emphasize Dr. Nefsi's point that the majority of health and well-being for the aging community comes from our primary care providers and primary care resources. My area of specialization, palliative medicine, is similarly complementary, but for a relatively narrow population, and those are those populations living with chronic, life-limiting or life-threatening illness. And so the earlier that the palliative medicine team is involved, the better that these patients ideally can live and can plan ahead of time while they're living with a chronic illness. And chronic illness for some patients might mean living a decade or more with a chronic illness, such as dementia. Even from the early onset of dementia, for example, when a patient can still speak for themselves and make their wishes known, we can take a lot of thoughtful time with advanced care planning, coordination of their medical care, to make sure that the continuum of their care is as well as it can be and aligned with those patients' wishes. And then I'll also add that the advanced care planning workshops are a valuable resource that are very well organized and coordinated to provide accurate general information to the community.
Thank you. I was listening to these questions and comments about our community's approach to things like shifting the paradigm to healthy aging now for those over 65. And I'm aware that there are cross-sector collaboratives in the Traverse City area on housing and also on food security. Does a similar network of private, public, and nonprofit leaders and organizations exist as it relates to aging? Maybe I'll ask Heidi to start.
Ironically, the day the pandemic broke, we were about to kick that off, and we got sidetracked. But it's something that we talk about frequently and would like to get back on the radar and organized quickly.
Any of our other panelists want to speak to that?
Again, I think that, there are formal processes, formal resources that we all know about and probably could do a better job coordinating and that kind of thing. But I do think part of what we're talking about here with the paradigm shift is cultural. And, we all have to be on the same page. It takes the village about making those connections. And those aren't always a formal thing. It's not as simple as knowing what resources are or understanding that they're out there, but it's actually making connections for people with maybe not a formal resource, but a more informal one, like, we talked about a choir or a book club or an exercise club or those kinds of things, and ensuring that those connections are made and that people are supported in that way.
Thank you. So we talked about the advanced care planning workshops that are hosted by Munson. What other information from the Health Forum can be translated into direct educational programming being done for older adults? Maybe Deb and Heidi could start on that.
I'd like to add that for the advanced care planning, that's also available through primary care physician offices, some of them, as well as through the Area Agency on Aging. So there's Stephanie does a wonderful job of training many of us in the community to have those conversations. I think the pandemic has changed a lot of the forums that used to be available. There were many more. We've been limited by the broadband issues, the technology issues, where we would be able to get many older adults into a room to have these conversations. I'm hoping that as the pandemic lessens, we will be able to get those forums back out into the community. I know through many of our agencies, we would offer workshops and courses on how to care for someone, how to manage chronic pain, how to manage your diabetes. It's time to get back out and doing that stuff.
What advice or resources are available for those in the quote unquote sandwich generation taking care of family, specifically concerning the caregiver burnout? Another question came in also asking about respite care. Dr. Braza, do you want to start with that?
Sure. So I can speak to the patients that we're seeing are in the palliative medicine clinic. Our medical social workers and psychotherapists actually invest a lot of time into not just the patients, but also sessions either exclusively with the caregiver or with the patient and caregiver, with developing strategies and learning techniques of coping, managing the stresses that come along with being a caregiver. So I think that's a valuable resources for those patients who are being seen in our clinic specifically. With regards to respite, within the general community, I know that oftentimes can be challenging to find. I'll maybe ask Heidi in a moment to speak to what respite resources exist, but I'll mention very briefly, one of the benefits of hospice care that I did not explicitly speak to is a part of the hospice benefit that's called the respite benefit. And what that is for a patient who's living at home and their caregivers meeting their day-to-day needs, oftentimes these caregivers experience a certain degree of caregiver fatigue or burnout, if you will, and the hospice service benefit will provide a respite care benefit where the patient can be moved to, for example, Munson's hospice house residence for a period of respite care of up to 5 days to give that caregiver a break, if you will, from the caregiver fatigue, if you will. So there are different programs. That's just one example of within the hospice benefits program that exists. But I know it varies from community to community about what respite resources exist in various communities. So I'll kind of pick on Heidi to see if she has better information than I do about that.
Thank you. So first, to piggyback on, we do have a team of nurses and social workers that can call, anyone can call as a caregiver, and we invest in our nurses and social workers on caregiver strain and burnout. So we will make time to sit with them. We'll do some assessments with them. We'll say, hey, where are you struggling? How can we either help you psychosocially or connect you to resources and do those assessments? So that's one avenue. I will confess that there's a wait list for that. In terms of respite care, it does vary by community. It also depends on your funding source. So we've just talked a little bit about the hospice benefit. There are some commissions and councils on aging where they will do it under senior millage. If you are in PACE or if you're in the My Choice Waiver Program or in your another AAA program, we're able to provide some respite care. We're able to pay for it, either for someone to come into the home or to maybe pay for a stay in a nursing facility. So again, it's understanding what you have financial capacity for. You can private pay for respite care. It's doing your homework and figuring out what your resources are.
And likewise, Grand Traverse Pavilions, we do offer both adult day programs as well as respite care, which is kind of like an overnight or extended overnight stays. So there are some of those options as well. I will say there's also a waiting list, and we've also had, you know, the challenges with staffing regarding those services. So it's best to call ahead if you have those needs and plan ahead for that.
Dave, you're muted.
I should figure that out after 18 months of doing Zoom calls. This comes from someone who's a patient advocate. And the question is, if the most trusted or qualified person is not local, can this be done effectively by phone, or is it preferred to be someone who can be there in person? Do any of our panelists want to speak to that question? Go ahead, Dr. Barraza.
So if a patient's advocate is only available by phone because they're out of state or at a distance, we frequently are engaging these patients telephonically through a speaker conference call with the patient present, even if they're in the hospital. So that advocate can be somebody who might be at a distance. Is it preferable to have them there in person? Certainly, it makes it easier and those conversations easier, but more critical is that individual, that advocate, somebody who knows you, knows your wishes, your preferences, your values, what constitutes a meaningful and acceptable quality of life. And if that has to be a person who's at a distance, that's the preferred person.
I would second that. I think that's consistent across the continuum.
Okay, I'm sorry we didn't have time to get to all the questions. Really interesting presentations today and some excellent questions. So I want to say thank you to our presenters for very interesting thoughts and advice. Also to our host, NMC and Grand Valley State University, and to our sponsor, Blue Cross Blue Shield, and of course, our audience, thanks for joining us today. If you want to continue to participate in our biannual health forums, the next one is scheduled for April 5th of 2022, where we're going to have another discussion about a health issue affecting our region and recognize individuals who have shown leadership in our region in the healthcare space with our community awards. So thank you again for joining us today, and thanks for really an excellent discussion. And I hope everyone stays well. Thank you.
Thank you.